Okay, so I'm going to go ahead and start the recording and we'll get going. Kind of a lean class tonight, only 9 people, but that's all right. We're going to be going over diabetes. I've been through this before. Yeah, I know, right? Like 20 times this year. You're going to run out of hurricane names. Like even the alphabet's going to finish up at this rate. All right. So, like I said, tonight we're going over not just diabetes, but this is the diabetes chapter. There's going to be some other stuff to it. We're going to focus on diabetes. We're going to talk about other endocrine issues as well as hematologic emergencies, which is to do with what? Based on that name, who can tell me what hematologic emergencies involve?
The liver.
Close. Close. HEM, not HEP, though. It's the blood. So tonight we're going to be going over endocrine and blood emergencies. Like I said, the bulk of tonight's going to be diabetes. Not that big of a deal. Um, it's not as complicated as people. Well, I mean, it can be a difficult thing to learn. I remember when I was learning this stuff, it wasn't the easiest out there. Even though I was exposed to it because I had family members that were diabetics. I myself had had a hypoglycemic emergency at one point back in high school. But it just learning it from a medical standpoint wasn't the easiest. But once I got it, you kind of look back on, you're like, why did I ever struggle with this in the first place? So tonight, because we're dealing with the endocrine system, I want you to think about the fact that this is all about the body's attempt to balance things, okay, and then its inability to do so. So we talked about in the anatomy chapter when we got to the nervous system, we talked about how your nervous system controls your body, right? If you need to pick up the pace and get a faster heartbeat, well, your brain has to tell your heart to do that, right? But the problem is that your nervous system is electrical. So it's either there or it's not. And it's either 100% there or it is 100% not. There is no middle ground, there's no gray area. So how does the body actually manage to do variance? Like how do you do, say, 50% or 30% or something like that? If you want just a 30% increase in your cardiac output, how does your brain cause that to happen? That's where the endocrine system comes in. The endocrine system, what's happening is your brain doesn't just zap the heart and say beat faster. Thankfully, what it does is it will apply an electrical current to your endocrine system, and for whatever amount of time that electrical current is hitting it, that endocrine gland is going to release a hormone, be it not epinephrine, that's what we inject, but like adrenaline or dopamine or any of the stuff that goes in there. Um, for however long that gland is being activated, it's going to release that much of that fluid, that hormone into your blood. Does the sound have a weird echo for anybody? Yeah. Anybody having a hard time hearing me? It could be that I'm in a, like I said, I'm in a hotel room. Um, my voice itself could be echoing. Okay, no problem. If it gets bad, let me know. Um, but anyway, so that endocrine gland is going to release a hormone for however long it's being zapped. And basically, what's happening is the body is saying, I want this much of a response, so I'm going to need this much of a hormone. As long as everything is working properly and the cells are able to connect with that hormone, and there's not too much of it or not too little of it, everything works like it's supposed to, then fantastic. We operate like we should. The problem, and this is what we're going to talk about tonight, is when a couple of things in that chain don't work right. Right. All right. So diabetes is a perfect example of that. So let's get going with the slides. All right, so your human endocrine system directly or indirectly influences nearly everything about you. We're talking about on a cellular level, because, for example, an individual cell needs glucose to create ATP, which is what we use for energy. But glucose can't just waltz right into the cell, right? That's like the homeless guy on the street trying to waltz into the expensive club. It doesn't work that way. So there's a hormone that we release. It's called insulin that the body needs to pair up with the glucose to get it into the cell. So it's almost like you could look at it like, well, now you've got a guy that looks like he doesn't belong in the club, but now he's got a girl with him. Or in a sense, you could kind of look at it like the bouncer as well, the guy that's holding the door open and saying, yeah, you're on the list. If any of those pieces are not there, then the glucose can't get into the cell, and then we run into some issues. So your endocrine glands, like I said, the system as a whole functions on almost everything you do requires the endocrine system. It's almost you could if you didn't need the nervous system to activate the endocrine system, then we would be saying that the endocrine system is what controlled everything. But you know, potato potato. Endocrine disorders are often seen with a multiple list of signs and symptoms. So when somebody's endocrine system is messing up, be it hypothyroidism, diabetes, whatever, they're, especially when they're in an emergency, their signs and symptoms will be all over the place. It's going to be like a systemic, sometimes multi-system issues, and you're like, what is going on with you? It's probably something hormonal. I mean, I hate saying it in that phrase because people take it the wrong way, but if you think about it from a medical standpoint, sometimes it really is just your hormones are off, and it could be your, like I said, your adrenaline's off or your insulin levels are off, and that can be causing you to have high anxiety or a different level of consciousness, all these different things. Hematologic emergencies are also, like I said, they're also a big part of this chapter we're going to cover. These are difficult to assess and treat in the pre-hospital setting because they usually require labs to figure out what's going on. They have to pull your blood, look at it, check to see how many white blood cells you got. What's your platelet count? Are your red blood cells carrying oxygen like they should? Is your H and H in the right range? These kind of things. But that being said, just because we can't figure out exactly what's going on with somebody doesn't mean that we can't make some major actions to save their life. A lot of it's going to boil down to, as you'll see when we get to that part of the chapter, it all comes down to your primary. Um, it almost gets redundant in all of these chapters saying the exact same thing in your assessment, but in a way it's a saving grace because you're going to show up and you're going to be looking at somebody and you're going to be rolling through like 50 different things that we've talked about in class that it might be, and you know their signs and symptoms can point to like 10 of them, but what do? Just follow through your assessment. We repeat it and we kick the dead, kick the horse for a reason, and so that it gets ingrained in you. So a real quick anatomy review. The endocrine system is a communication system that controls functions inside the body. And this is what actually does the direct controlling, like I was saying. And this is what is turning the gauges to where they need to be, or turning the dials where they need to be and everything. It's not just on off like the neurologic system is. Your endocrine glands will secrete hormones. They're messenger hormones. They basically say for the body to do something, and they will float around in the bloodstream, like say adrenaline. Adrenaline, anybody that's aware of what that does, that basically is your amp up fight or flight hormone, right? That's the one that kicks your heart into overdrive. You hear about people picking up cars off of loved ones because of their adrenaline rushes and all that. But the adrenaline by itself doesn't make you do that. What happens is your adrenaline gets dumped into your bloodstream and is floating around, and it's not doing anything until it attaches to a good receptor that can take that and say, oh, cool, I know what to do with this. And then it ramps up. So there, and again, you can see every receptor is almost like a puzzle piece. So a dopamine receptor is not going to accidentally pick up a adrenaline hormone or an insulin hormone or something like that. If it doesn't fit, it's just going to float on by. But that's basically what's happening there. Your hormones are chemical substances produced by the gland, and endocrine disorders are caused by an internal communication problem. Usually, it can be anything from an electrical issue in the brain to maybe your gland itself is not responding to the issue, or it's responding too well to not issue, but not responding to the electrical stimulus, or it's over responding to it based on some other kind of medication or something that may be in your system. So when we talk about diabetes, and that's like I said, it's what we're going to get into first. First of all, we need to figure out what's going on. Why? Before we talk about the disorder, let's talk about what should be happening. So your brain needs two things to survive. I've said it before. You need glucose and oxygen, and it's the biggest baby in the body. The minute one of these gets out of whack, the brain is going to pitch a fit, right? You're going to have higher anxiety, level of consciousness changes, all that stuff. Insulin is necessary for glucose to enter the cells. That's your bouncer or your date, or however you want to look at it with the club scenario. Without enough insulin, the cells do not get fed. So we run into that's where your balance comes in. You either have the right amount of insulin to keep your cells fed, or you have too much insulin, or you have not enough, right? That's pretty much your three ranges. If it's not in the right range, that is a diabetic emergency. It can be either too high or too low. But what we want is that good balance that says, all right, all the cells are getting glucose like they're supposed to, and we have enough reserves in the bloodstream just to get by. And that's when we're measuring somebody's glucose, we're looking at what's in the blood, not what's in the cells. So keep that in mind, because there's sometimes that's going to make a difference. All right, so your pancreas produces and stores two hormones. You have your glucagon, which is basically a stored version of glucose, and insulin. Inside the pancreas, and you, all right, so like I said, if you're an anatomy guru and you want to know how the pancreas breaks apart, fantastic. At the basic level, I don't need you to necessarily remember the Isle of Langerhans or anything like that. If you're going to go on to our advanced EMT or paramedic program, then absolutely know this, because this is a testable. This is something that you really have to understand with how the pancreas itself breaks apart. But within the islets, you have two kinds of cells, alpha and beta. Your alpha creates your glucagon, your beta creates your insulin. And that's all we're really going to say about that at this level. The pancreas stores and secretes insulin and glucagon in response to the level of glucose in the blood. So if your blood sugar starts to rise, what do you think the body is going to release? Is it going to release insulin or glucagon? If your sugar is getting high. People are bouncing out. Yeah, we don't have a lot of people in class, so those that are here are going to have to kind of be active tonight. Not a lot of people to answer. Right, insulin. So here you go. All right. So yes, if your glucose is getting high, your body is going to release the hormone that brings it back into balance. So if your glucose is high, we need to get something in there that brings it down, which is insulin. If your glucose is low, then your body's going to they're not going to dump glucagon directly into the bloodstream, but what it will do is it will break the glucagon, transform it into glucose, and dump that into the bloodstream. Because remember, your glucagon is just basically stored glucose. And it goes back and forth. Your body maintains its homeostasis by dumping whatever it needs to keep that baseline. If you eat and you spike your blood sugar because you ate something, then you're going to get insulin dumped into your system. If you start fasting and your blood sugar drops because we're using it, then your body's going to start to dump that glucagon into the system. Okay, for your pathophysiology, this is where things start to go wrong. So we're going to talk about diabetes itself. Diabetes mellitus is a disorder of glucose metabolism, such that the body has an impaired ability to get glucose into the cells to be used for energy. It can be, like I said, it can either go up or down. It's just not where it needs to be. This affects almost 10% of the population, 9.3, which is an insanely high number when you're looking at this as just gross population. And it's interesting because when you start breaking it down, I remember a couple years back when I was going through training to be a personal trainer. Um, if you're overweight, your chances of getting, as far as the population goes, when you look at just the overweight and obese population, about 87% have type 2 diabetes. Like it was almost, if you were overweight and not taking care of yourself, you were going to get it. It was that high of a percent. I don't know where it's at now. That was about, I don't know, 10 years ago that I went through that training, but I'm sure it's not really that much better. Um, Without treatment, your glucose levels can become too high. In severe cases, this can cause life-threatening illnesses, a coma, or death. We have actually seen people die of untreated diabetes. We've seen people lose limbs because of untreated diabetes. It's not pretty. It's not fun to get it. The good thing is, it's type 2. You can kind of kick it, but a lot of it comes down to your lifestyle choices. So if you don't manage it well, it can have severe complications like blindness. In fact, I had a regular, I'll say frequent flyer down in Poplarville that was a known diabetic who every time she had an episode, blindness was the big thing, which was scary because she used to drive herself to the Sonic to try to get something to get her sugar up, knowing that her vision was going to go when things got bad. Cardiovascular disease and kidney failure are also some issues that you can run into. There's three types of diabetes. Everybody always knows the type 1 and type 2. But what we don't always talk about is the gestational diabetes, and we're not really going to get too much into it tonight. I just want to make it there. This typically happens during pregnancy, hence the name, and it usually goes away when the pregnancy goes away. But it is a type of diabetes, so they're mentioning it here. Type 1 is insulin dependent. We're going to talk more about that. Type 2 is insulin resistant, and we're going to talk more about that. You can have either high or low blood sugar when you're dealing with type 1 and type 2. They have the ones that they like, one will trend a certain way. For example, type 1 diabetes, if you're not using too much of your insulin, if you just let it go, so you got off of your medication, your type 1 diabetes is typically going to be hyperglycemia. You're going to climb, even though there are instances where it goes the other way, and we'll talk about that. Type 2 diabetes, that one actually, you're really more prone to see hypoglycemia, which is the bad one because it hits you harder, it hits you worse, and it's a lot more unsafe because that's where you very quickly go into an altered level of consciousness, and the nicest person you know may try to kill you because they're in their fight or flight and they don't know you from an attacker. All right, but just remember your terms. Hyper means high, so when we're talking about that, hyperglycemia is high sugar in the blood. Hypoglycemia is low sugar in the blood. That's how the words break apart. Give me a second. Let me make sure I'm with the slide. I don't want to get too far off track from what your slides say, especially with the recordings, because then it starts to confuse people in the recordings when you watch it after the fact. All right, so let's talk about diabetes type 1. This is an autoimmune disorder in which the immune system produces antibodies against the pancreatic beta cells, which is your insulin. So your pancreas is building insulin, but your body's fighting it off. Your body's killing it off. And if the insulin is not active in the bloodstream, that means you can't get your blood sugar or you can't get your glucose out of the bloodstream and into the cells, right? So your blood sugar just kind of starts to climb. And that's where your problem comes in. So people with diabetes type 1 have to take insulin injections. They have to actually give themselves extra insulin to keep their blood sugar where it needs to be. And when they are up on their meds, then fantastic. But it's not just their meds they got to keep up with, it's also their diet. So if they aren't feeling good one day and they decide not to eat, or they got food poisoning and they decide not to eat, or they don't get to digest what they ate, their insulin is going to drive their sugar down. So if they're taking their meds and this happens, then now you're going to deal with a hypoglycemic emergency. If they are not taking their meds, so they forgot to take a dose, they overslept, they missed their time to do it, and they ate, or it's the holidays and they ate way more than they usually do, but they didn't adjust their insulin accordingly. They can throw themselves into hyperglycemia. Um, Sometimes it happens. So this is a tricky one because first of all, you don't really get this one from a lifestyle choice. This is one that you either are born with or your body just develops it. Um, but you have to be so good as a patient, as somebody with this, balancing your food, your drinks, your insulin shots, all that stuff, that it's really easy sometimes to get out of whack with it, especially when things go wrong, like if you start to get sick. It's real easy to let things get out of that balance. Onset usually happens early in childhood through the fourth decade of life. So in your 40s, if you make it into your 50s, you could still get it. It's not saying that you can't. It's just that it's not as common. The immune system destroys the ability of the pancreas to produce insulin. Eventually, you're just not going to produce it anymore. So you have to get it from an external source. You can't live without it. Patients that have type 1 diabetes are eventually, hopefully, going to wind up with a pump, and that pump will take care of things. And then they only have to focus on the one thing, which is eating, right? Um, but again, if they miss a meal, that pump's not going to know when they miss a meal. The pump's just going to keep dumping insulin like it's supposed to. And that's when the pump works. If the pump messes up and it either stops putting in insulin or it starts dumping too much, then we run into problems there as well. That's going to be sometimes when you respond to type 1 diabetics, a lot of times it's either going to be that they made a mistake with their nutrition or their pump is doing something it's not supposed to be doing. Patients who inject insulin often need to check blood glucose levels up to 6 times or more a day. Anybody remember those commercials with the older guy who I forget what the commercial was, but he's always talking about the way to check his blood sugar, and now the best part is you don't have to prick your fingers anymore. That was so sad the way he would say that. Anybody remember those? I forget what it was. It was like a new glucometer or something. But yeah, that was basically for type 1 diabetics. These commercials were old. I want to say, actually, I was probably in college, so 16, 17, 18 years ago, somewhere around there. Maybe not quite that far back, but um, I know they were pretty far back. Many people with type 1 diabetes will get that insulin pump, continuously measures glucose levels and provides insulin and correction doses of insulin based on their carb intake sometimes. But again, um, if they miss a meal or something like that, sometimes it's a little bit harder for that pump to keep the right amount, and then you run into the problems. These can malfunction. In fact, they usually do. It could be something as simple as the batteries died. It could be that it got bumped and jarred, and now it's not wanting to function properly, or where it actually injects, maybe the injection port got clogged up or came disconnected from them. It really just depends. You could use alternate sites. So yeah, you can. Um, I was just referring to the fingers. Anywhere you want to prick somebody, you can. You can prick them in the earlobe. You can prick them um, in the fingers, which, like I said, we'll get into that mostly at the boot camp. We'll talk about how to check somebody's blood sugar and everything. So we'll skip that part tonight. Um, at least as far as the how to. We'll talk about it and like what we're doing and maybe some tips, but a lot of that will be done in person. If you do show up to somebody with a messed up pump, um, or even if you don't know if it's messed up, ask about it. Say, ask if there's a pump, ask if it's working properly, ask if they've changed the batteries lately, if they think the batteries might be dead, or if they hit it, maybe they bumped it on something, that kind of thing. Type 1 is the most common diabetes of childhood. In fact, that's why for a long time we used to call it pediatric diabetes or childhood diabetes, that kind of thing, is because typically this is the diabetes that you got as a kid. This is before kids were getting type 2 diabetes because 9-year-olds were eating so bad that they looked like linebackers or just severely overweight kids. Now it's that line is blurred, so can't really say that anymore. Type 1 diabetes is the most common metabolic disease of childhood, like we said. Some of the symptoms you're going to see: polyuria, polydyspia, polyphagia, weight loss, fatigue. Sometimes you may see dehydration. Sometimes you may see um, the urine is going to have a sweet smell to it, depending on what's going on, because if your blood sugar is high, what's the easiest way to get rid of something in your blood if it can't be absorbed by the cells? Anybody think of any organs that we have that, yeah, you just pee it out, right? Your kidneys pick it up and dump it out. So if we got too much blood sugar and the insulin's not taking care of it, our backup is the kidneys. And so if that's the case, then when you go to the bathroom, your urine's going to smell sweet. It's going to look like sweet tea, even if you're hydrating. And it's going to have a sweet smell to it. That's actually one of your signs and symptoms. So if you're talking to a patient who may not know they have diabetes, say it's type 2, and there is a new onset for them, they may not know any. So if it looks like that's what you're dealing with, that could be one of your assessment questions: is, hey, have you noticed a difference in your urine? Is it darker than usual and smell like it's got sugar in it, something of that sort? And if they say yes, or if they're like, come to think of it, yeah, it does smell kind of sweet. That's a big sign that you're probably dealing with diabetes on the high blood sugar side. So, all right, here we go. This is just what we were talking about. Just for the definitions of your terms, polyuria is frequent urination, so they're going to the bathroom more. Polydipsia is an increase in fluid consumption. Because they're going to the bathroom more, they're typically going to want to drink more. Not to mention, they're going to have like dry mouth, and that'll be something that's a symptom they may tell you is that I can't stop, I can't quench my thirst. My mouth is dry all the time. Polyphagia, severe hunger and increased food intake. When the glucose is unavailable to the cells, the body starts turning to fat for energy. Sounds a lot like a diet going around that I'm actually doing right now, and I'm enjoying it. But this is going to kind of mirror that. When the body turns to fat rather than glucose, it produces acid waste called ketones. And as the ketones levels go up in the blood, they'll spill into the urine. So just like the diet, if anybody has done keto, best way to figure out if you're in ketosis is to get those pee strips and actually pee on them and see if they're, if you have ketones in your urine. That's what you're checking for. You're in ketosis at that point. So why then is keto okay, but not diabetic ketoacidosis? What's the problem? What's the difference? Because in both of them, your body is turning to fat for its energy. You're getting ketones in the blood, ketones in your urine on both of them. There's a stark difference between some of it, though. Pretty good guess, yeah. So your pH balance will get out of whack if you're on diabetic ketoacidosis. That's actually why we get that, why we call it that. Let's see. Fine line, non-diabetics can compensate, diabetic can't do the pancreas. Yeah, so you're pretty much on it, Donna. Another issue too is that your glucose may be fine. Your glucose may be high. It's just not getting into the cells, or the body is registering that it can't take care of it like it should. So it's having to look to the ketones. Diabetics that are having this problem are not going into ketosis because they're not eating carbs, which is where we get our glucose from. The problem is that the glucose may be there. So in addition to it, you're having that ketosis. There's a difference between the controlled ketosis of a keto diet and the something is wrong ketosis of diabetes. But anyway, kind of going down this ketoacidosis route, which is where your acidity starts to build up in the bloodstream because we're breaking down fat, which is normally a good thing, but the ketones are just spilling into your, they're going up in the blood and spilling into the urine. With that means that your pH balance is going to drop, right? The acid side of it is going to go up. So we're getting lower in the numbers. Your body is going to try to buffer that. We try to stay at that 7.35 to 7.45 range. And so to bring our acidity back down, your body's going to do what it always does, which is make you breathe faster. So patients are going to breathe faster and deeper, and as the body attempts to reduce the acid level even more, they're just going to continue to do that deep, fast breaths. Eventually, it's going to get to a point where they're breathing 24, 30 times a minute, whatever, but they're really deep breaths. They're not doing it because they're trying to bring in oxygen. They're doing it because they're trying to get out the carbon dioxide to bring their acid levels down. We call those Kussmaul respirations. Sometimes you'll see those in head injuries, but you can also see them in uncontrolled diabetes. If fat metabolism and ketone production continue, a life-threatening illness called diabetic ketoacidosis can develop, or DKA. DKA may present as generalized illness along with abdominal pain, body aches, nausea, vomiting, and an altered mental status whenever it starts to get bad, right? Unconsciousness can happen as well. When they start to actually go out on you, that's when it's getting pretty bad. If you don't recognize it, it can result in death. There's really not a lot that we can do for diabetic ketoacidosis as basics. In fact, there's really not a lot that even a paramedic can do, because what's happening is like you can see here, if you were to check their blood sugar when they're in DKA, generally you're going to be higher than 400. And here's the problem with that. So we know if somebody's blood sugar is low, we just give them sugar to bring their sugar up, right? We can give them either oral glucose, or we can use cake icing, which I highly recommend because it tastes better. But either way, we're going to give them some kind of sugar to bring their number up. But if they're high, can you guys think of anything we can give in the field at any level to bring somebody's blood sugar down? Nothing. Doesn't matter if you're an EMR or a paramedic, there's nothing we can give in the field to bring somebody's sugar down. The only thing that will do it is insulin. And because that is such a process, I guess you could say, to do it properly, it only really happens in the hospital. So this is something that even the paramedic is going to be like, we need to go, like right now, get in the truck, let's go. So this is one of those things that we want to try to, if we're able, we want to try to stop it from getting to this point. But unfortunately, when their blood sugar starts to climb, we really can't. The saving grace is that hyperglycemia doesn't happen fast. It's not like hypoglycemia where it comes out of nowhere and it goes from 0 to 100 real quick. Like hyperglycemia usually is a little bit slower of an onset. So unless they're already way behind the curve by the time you show up, typically you got time to get them to the hospital and not be a problem. That's all right. But yeah, if you show up and somebody's blood sugar is high, go ahead and get them to a hospital unless if they're a known diabetic and they have their own insulin and they take it or whatever, it's up to you. I still would try to get them to a hospital just in case, because I mean they had the insulin already and they either didn't take it or it didn't work. So I'd rather have them in that controlled environment. I'd be trying to talk them into going, because there's nothing I can do. I'm about as useful as the police at that one. So get them there. All right, moving on to type 2. This is caused by a resistance to the effects of insulin at the cellular level. So it's not that the insulin's not there. The insulin is there. So we don't need to give ourselves insulin shots for type 2 diabetes. What's going on, though, is that basically the bouncer got fired and he's not allowed to bring anybody into the club either. So just because he's there, but he's kind of stuck out on the street with you and he can't do anything to help you out. there is a massive association between obesity and increased resistance to the effects of insulin. Type 2 diabetes and obesity is, like I said, it's something like 80% or higher. I don't know what the numbers are now. The pancreas produces more insulin to make up for the increased levels of blood glucose and dysfunction of cellular insulin, but it just doesn't work. All right, so the insulin, again, the insulin is floating around, it's just not doing anything. Your glucose levels will continue to rise, and they don't respond with the pancreas when the pancreas secretes the insulin. This is called insulin resistance. So you may hear somebody say, instead of saying type 2, they may say they have insulin resistant diabetes, as opposed to type 1, which is insulin dependent. We treat, especially as EMTs, we treat type 2 diabetes with oral medications. So oral glucose, like I said, you can use cake icing, especially if it's a kid. Um, yeah, it was probably a bad diet that got them there, but why make them suffer? Let them get something that tastes good. Um, get them to where we can fix them and get their blood sugar up. If their sugar's high, like they're hyperglycemic, then that's not going to help. Um, but like I said, if we're trying to bring it down, if we know it's high and we're trying to bring it down, the only thing that's going to help is diesel. Get them to the doctor, get them to the hospital. If their sugar is down, then we can give them the oral medications. The only thing I want to say about that though is if they're not awake, conscious, talking to you, don't give them anything by mouth. So because they're going to choke on it, right? They're going to aspirate it, and then now you've got much bigger problems than some blood sugar, um, as to what they called you out for. All right, type 2 is often diagnosed at a yearly medical exam from complaints related to high blood glucose levels, including recurrent infections, changes in vision, numbness in the feet. Again, especially when it goes unchecked, your extremities are going to become problems. If it gets really bad, they're going to wind up having to cut them off. I actually had a person in Poplarville that was a frequent flyer for us because she didn't have, I don't think she had, I know she didn't have one foot. This is right when I became a firefighter. I don't think she had either one. I think they had to amputate, um, because she just wasn't taking care of her diabetes. Symptomatic hyperglycemia. Um, what does that mean to you? I'm gonna let y'all say something for a second.
Well, if it's hyper, that means it's very active. So I would assume that that means your levels are extremely high.
Yes, so your levels are high. That's what the hyper is. So good job. Your levels are up, but it's not just that your blood sugar is high because we can get some high blood sugar. We eat a bunch of candy, um, sugar treats, and my weakness, Reese's peanut butter cups. We can really spike our blood sugar. It happens, but it doesn't mean that we're going to throw ourselves into a crisis over it every single time we eat candy. So that's where this is. This is symptomatic, means that it's not just high, it's high enough and it's been high enough long enough to give you problems. Think about it like when we talked about cardiology, when we were in the cardiology chapter. Hyper, I'm sorry, not hyper, we'll say bradycardia, right? You get somebody that runs marathons for a living, their heart rate may hang out at 40. That's bradycardia. But if that's normal for them, they're not going to have any symptoms. But if somebody's sitting at 40 for a pulse and that is not normal for them, and they're having problems staying awake and all these other circulation issues, that's symptomatic bradycardia. So the same thing here. Hyperglycemia by itself sometimes is normal for people, especially depending on their diets, like I said. But it's when it's high with symptoms. So symptomatic hyperglycemia. This occurs when your blood glucose levels are very high and the patient winds up in a state of altered mental status resulting from several combined problems. In type 1 diabetes, this leads to ketoacidosis with dehydration from excessive urination. In type 2 diabetics, it's non-ketotic hyperosmolar state of dehydration. This is actually worse. This is due to the discharge of fluids from all the body systems and eventually out through the kidneys, leading to fluid imbalance. So we've got like a much bigger issue. DKA is bad. All right. The hyperosmolar state is actually worse. In fact, DKA can lead to it, even in type 1 diabetes, if you don't do anything to get it down. If an individual has hyperglycemia for a protracted length of time, so a long time, consequences of diabetes may present wounds that don't heal, numbness in the hands and feet, and they can wind up getting amputated, blindness, renal failure, which is what's renal failure? What's failing if you have renal failure?
Kidney.
Kidneys, right? Because they're working overtime. When you're in these problems, they're pushing fluid out left and right. They're really redlining for a long time. If they don't get a break, um, you can have renal failure. And then gastric motility problems will also start to kind of become an issue because of problems with your liver is going to be also working overtime. Um, when blood glucose levels are not controlled in diabetes type 2, a condition known as HHNS, is that on this slide? No, it's not on this slide. Sorry. There you go. The hyperosmolar hyperglycemic non-ketotic syndrome, HHNS. You don't have to remember what it stands for. If you just recognize HHNS, you should get it on all your tests. It won't be an issue. Key signs and symptoms of this include hyperglycemia, so your sugar is starting to climb way up. Altered mental status, drowsiness, lethargy, which is where you just start to kind of get sleepy. Severe dehydration, because your body is trying to get that sugar out of you one way or the other. And if your insulin can't do it, then your kidneys have to pick up the slack. Thirst, because you're losing all of your fluids. Dark urine, visual or sensory deficits, partial paralysis or muscle weakness, and seizures. Higher glucose levels in the blood cause the excretion of glucose in the urine. Like I said, your kidneys are picking up the slack. Patients respond by increasing their fluid intake, which causes polyuria. Now you're having to go to the bathroom more often. In HHNS, the patient cannot drink enough fluid to keep up with the exceedingly high glucose levels in the blood, and they will just continually dehydrate. The urine becomes dark and concentrated despite the fact that they're drinking that much more water. So that should tell you something, right? If they're drinking like a fish, and they're still not being clear, that means that their body is trying like hell to dump their glucose out because it's way, way, way too high. If you were to take a blood sugar on somebody like this, if you even got a number, it would be over 400. A lot of your glucometers in the field will just tell you high, HI. That's all you get. It's too high for it to register. The patient may become unconscious or have a seizure activity due to severe dehydration, and be careful because when their mental status starts to suffer like that, like I said, safety has to become a big priority. You have to watch yourself because if they go into that fight or flight response and they see you as a threat, it, it could be your grandmother. It's not going to matter. She may not even see you. Her vision may be gone. So she won't know what's going on. They'll start fighting. Symptomatic hypoglycemia. This is the other end of the spectrum. This is your low blood sugar. This is an acute emergency. These come on fast. So hyperglycemia actually is a slow onset. Let me add that before we get onto this. Let's say you show up to a patient and you think that his glucose may be out of whack, but you don't have a glucometer. So you can't get a number. You don't know if he's high or low. When in doubt, unless, like I said, unless you see those signs of HHNS and he's very, very far off the deep end, and you know based on that he's super high. If it's just his vitals are a little out of whack, his blood pressure is sky high, or he seems drunk, that kind of thing. If you're not really sure, err on the side of hypoglycemia and give him sugar anyway, because hyperglycemia is a slower onset. He's going to go to the hospital. He's got an altered level of consciousness. So um, they can check his blood sugar there and give him insulin as needed. If he's hypoglycemic and you don't give him sugar, that's a problem that's going to get worse that could have been fixed if you did try to give him the sugar. Anyway, on to hypoglycemia. These come on fast. This is where their blood sugar drops really quick. This can occur in patients who inject insulin if it's type 1 or use oral medications that stimulate the pancreas to produce more insulin. When insulin levels remain high, glucose is rapidly taken out of the blood. So if somebody were to, let's say it's a type 1 diabetic, and they give themselves insulin, and then they get distracted and they forget to eat. Um, they have more insulin in their system than they do glucose, so the glucose levels are going to drop. We can compound that with geriatric patients I've seen where they'll take insulin, then get either sleepy or distracted with something, forget to eat, and then forget that they took the insulin. So they take another hit of it, and now they're really bad off. And these are the ones that aren't fun because no matter how we try to give them sugar, it's almost like it's not enough. There's so much insulin in the system that we'll go through bags trying to get their sugar up. And as a basic, it's that much worse because you only carry so much oral glucose. You'll run out of it, and there's so much insulin that it's tanking their glucose even as you put it in. Sometimes you deal with that. So what you do is you just give it to them. Wait a minute, take a glucose, see where you're at. If you need more, give them some more. Wait a minute, take a glucose, see where you're at. Anyway, the mental status of the patient declines and he or she may become aggressive or display unusual behavior. It's a lot more common to see that in hypoglycemia than it is in hyperglycemia, but you can see it in both when their mental status starts to go. But it comes on really, really quick. Like there was an example of somebody with an altered mental status could be a lady that we saw in a grocery store once that she felt it coming on, and she was a known diabetic. She knew what was happening. She grabbed a chocolate bar off the shelf and just opened it up. Was going to try to eat it, but before she could get it into her system, her mental status changed on her, and we found her sitting with her pants down in the produce section with chocolate around her mouth, and it was. I felt bad. Like we didn't know what to think. We thought maybe you're thinking drugs and who knows what. Um, we took her glucose. Anytime somebody has an altered level in consciousness, always check a glucose. So we did, and it didn't even give us a number. It just said low. That was it. So we gave her sugar. She came to realize what was going on, and well, we'd already covered her up, but still, she's like, "Oh my God!" And she put her clothes back on and everything, and explained what had happened. Um, it came out of nowhere. It came out that fast, like it was almost like a seizure. She realized it was coming, but it hit her so fast she couldn't even get the nearest chocolate bar unwrapped and really in her mouth very well before it was too late. If it gets worse than that, unconsciousness and permanent brain damage can quickly follow. So you want to stop that curve before it gets there. Common reasons for common reasons for low blood glucose levels. Correct dose of insulin with change in routine. So they took the right amount of insulin, but they either exercised more or didn't need enough. If they took too much insulin, if the correct dose of insulin without the patient eating, correct dose of insulin, the patient developed an acute illness. So this time of year, I know we're already starting on the flu shots and things like that. Um, this is a time of year where you're going to start to see this more often. Like she had an aura, like she could feel it. She could like, okay, I'm starting to get this tingle. Um, every time I get this, it's because my sugar is dropping. Eat my weight in peanut butter cups. Absolutely. That's the thing I think I miss most of all the I love keto and because I can eat. I love everything that I get to eat, but I really miss the things that I can't. Hypoglycemia develops much more quickly than hyperglycemia. We talked about that. So in some cases, if you don't know, just err on the side of hypo and give them sugar. Some signs and symptoms for low blood sugar: normal to shallow or rapid respirations, pale, cool, clammy skin. This is going to kind of mimic shock. If you guys remember your signs of shock, so pale, moist, cool, clammy skin, sweating, dizziness, headache, a rapid pulse. Here's one thing about it though: is their blood pressure is going to drop. Your blood pressure is going to kind of do what your glucose is doing. If you're in hypoglycemia, you may wind up with low blood pressure. If you're hyperglycemia, you're going to have a blood pressure to match it. The last really bad hyperglycemia patient I worked, I couldn't even get a number with the manual blood pressure cuff. His systolic was above the limits of the gauge. We had to use a monitor to get a number. Altered mental status, anxious or combative behavior, seizures, fainting, coma. weakness on one side of the body, because again, remember, this is the brain's being affected by this. So you might have what looks like a stroke and it winds up being a diabetic emergency. Rapid changes in mental status. Hypoglycemia is quickly reversed by giving the patient glucose. Just remember, as a basic, you have to do it orally. So if they are already starting to lose consciousness, your steps are done. There's nothing you can do about it. You have to get higher level of care to get them the glucose that they need, because they're going to have to inject it through an IV or hit them with a shot, like a glucagon shot or something of that sort. All right. But if you don't get the glucose to them, the patient's going to it's just going to deteriorate even more. It can lead to permanent brain damage. And yes, because hypoglycemia comes on so fast, minutes do count. All right. We're going to take a little bit early of a break tonight because we're changing gears into the patient assessment already. Or, well, yeah, we'll do that regardless. However, before we all just disappear for 10 minutes, does anybody have a question about what we've covered so far? I feel like we're moving faster tonight than usual. Okay. All right. Take 10 minutes. Be back at 7:03, and we will continue on with the patient assessment. This is patient assessment regarding what we just went. Yes. So every night, um, your patient assessment has to do with what we're covering. So this will be a diabetic patient assessment. Okay, we're gonna go ahead and get back started again. And we're only like a minute shy of the 10, so. All right, so let's talk about the patient assessment for diabetes. Very first thing we always do, no matter what, was step one.
BSI.
BSI seen safe, right? Good. All right. Especially with these and any other call that might make your patient not quite in their right mind. Um, just because that's it's major, right? It could be your grandmother, it could be the nicest person on the planet. But when they're in an altered level of consciousness, they could still attack you. They can hurt you. So just be aware of that. Always wear your gloves. Always make sure that if the scene is safe, great. If not, can you mitigate that danger? If not, then wait till more help arrives. But when you're dealing with diabetics, especially when you're talking about type 1 diabetics, there's a couple other things you want to watch out for. So be careful of the presence of syringes, because if they're giving themselves insulin shots, say that they don't have a pump, for example, um, if there's syringes and needles laying around before at the point when they went into their altered level of consciousness, they may not have had the foresight to recap needles or put them in their sharps containers or whatever it is that they do with them. So you could have some needles around that could stick you. So be very close, pay close attention to where you put your knee. If you're gonna take a knee by your patient, be very careful with what you reach for. If you're reaching onto their table, that kind of thing, or if you're gonna reach around them, because they may just drop the needle down like in their lap or kind of tucked around beside them in the chair or whatever, and you go to grab them to maneuver them, and you wind up poking yourself in the finger. So be very careful of that. It happens a lot more than I care to admit. Um, People stick themselves all the time, and it's not by anything blatant. Usually, it's because they just didn't see the needle. Um, be alert for clues that can kind of help you figure out what's wrong with the patient. Because again, at this point, we really don't know that they're diabetics. Even if they are, we don't. That's the problem. Diabetics get sick too from completely unrelated things to their diabetes. But keep an eye out for things. Look for syringes, insulin bottles, a plate of food, glass of orange juice, anything they might have been using to fix their sugar that may help you decide what's possibly wrong with the patient. Use your standard precautions, which is your gloves, and like I said, I see the writing on the wall. I think that eye protection is going to become standard as well. Question bystanders on the events leading up to your arrival, if there are any, and keep open the possibility that trauma may have occurred, especially if you find your patient laying on the ground. Right? If you don't know how they got on the ground, consider C-spine. It won't hurt to put a collar on them if you need to. Determine your mechanism of injury or your nature of illness. Form your general impression. Again, this is, sick or not sick, which if they're altered, that's definitely sick. And how does your patient look? Are they anxious, restless, listless? Are they apathetic or irritable? Any of these kind of signs could lead you down the diabetic route. Identify your life threats. You're in your primary now, so your ABCs is what you're going to be dealing with. Get your AFPU if you need to. If you're starting to think that it's a diabetic, especially if they're altered, call for ALS, because the minute they get altered, you really can't do anything for them at that point. You can't give them anything by mouth because they may aspirate it. And they may not even know they have diabetes. So keep that in mind. You may show up to somebody that's looking like they're going to have diabetes, but there's no sign that they have any clue about it. All that stuff we listed up above, none of it's there. Assess the blood glucose level if you have the proper equipment. You all will have the training. We're going to train you in how to do it. But again, some systems, for whatever reason, they're still not on the glucose bandwagon for EMTs. So we'll teach you how to do it, because you may go to a system that allows it. I don't want you to get there and be like, I don't know how to do that. But always, always, always read your protocols for what you can do in your system. And hey, if it's not allowed in your system, it may be because somebody never thought to go in and say, yes, you could do it. So you can always bring it up to your med director and be like, hey, you know, 50 years ago, they started letting EMTs do blood sugar sticks. Can we do these? that kind of thing. Perform C-spine if you think there may be trauma. And remember, always carry out a thorough, careful primary assessment, paying attention to your ABCs. That's going to be big in everything that you do. If you miss your ABCs in any of your assessments, it's an automatic fail. Patients showing signs of inadequate breathing, be it that their pulse ox is less than or equal to 94%, or their breathing just doesn't look right to you, put them on a high flow non-rebreathing. You can always step it down later on if you need to. I like to say go with the cannulas, but when you're dealing with an altered level of consciousness or something of that sort, go ahead and go to a non-rebreather and then check it as you go through your assessment. You can, like I said, you can bring it down from there. Hyperglycemic patients may have a rapid and deep respirations and sweet, fruity breath, which is why they used to get picked up as being drunks all the time. When the cops would get there, they'd smell that sweet smell in their breath. They'd mistake it for alcohol and arrest them for being drunk. When really what they are is in diabetic ketoacidosis at this point, right? Because they're trying to blow off that high acidity. And so they wind up dying in the cop car or dying at the jail or something like that. They've gotten a lot better. And it's not because they just didn't know. This training was not available to them, but because we are learning more about it now, they're learning more about it because we all work so well together and so closely together. Hypoglycemic patients will have normal or shallow to rapid respirations. If the patient's not breathing or having difficulty breathing, then we're just going to do what we do in everything else. Open their airway, insert your airway adjunct, whichever one you want to use, which in this case usually will be the nasal, unless they're just stone cold out of it and don't even have a gag reflex, and you can go with the OPA. Administer oxygen, assist for your ventilations if you need to. If they're not adequate, you got to bag them. Continue to monitor ventilations throughout patient care. No matter how far you get into your assessment, you have to make sure their breathing stays good. Assess their circulatory status. So when you get to C, you're going to look far and be aware that you may see dry or warm skin, which means that their sugar is high. If it's moist and pale, like they no longer have blood flow to their skin, that's hypoglycemia, and that's actually the reason why. It mimics shock for a reason. If you think about it, your body says that the brain and the organs that matter have to get the right amount of sugar. So if your body is going to be low on sugar, do your fingertips really need to get the right amount of glucose? Not really. So your body can treat it like shock. It will shunt off blood flow to the extremities to keep most of your blood in the trunk and in the head where it matters, so that the sugar that you do have is available to the organs that you absolutely need to survive, like your heart and brain. And so because of that, you're going to get that moist, pale skin. Hyperglycemia, it's kind of the other way around, right? They're saying, hey, too much, get some of this away. And so you're going to notice that their skin starts to get red because their blood vessels are dilating out in the extremities to try to get that blood somewhere to go to get it away from the heart and brain, because they don't need that much sugar. All right, so let's see what we got here. The difference from hyper and hypo is hypo sleepiness, pallor, hunger, sweating, irritability, lack of coordination. Hyper is headache, weakness, dry mouth, frequent urination, blurred vision, and increased thirst. Correct. Yeah. A lot of times your hyperglycemic patients are the ones that are mistaken for drunks because of those signs and symptoms there. Make your transport decision. If they're altered, it's going to be a high priority for transport. If it's a scenario of any sort, it's going to be a high priority for transport. Patients with altered mental status and impaired ability to swallow should be transported promptly, because you're going to wind up having problems with their ABCs, particularly their airway. Patients capable of swallowing and conscious, you have a little bit more time. They're not that far down the drain, and if they need it, you can give them oral medications at this particular point. For your history taking, investigate the chief complaint. In other words, if it looks like it's a diabetic emergency, don't sit there and stare at the foot looking for broken bones that don't exist. Stick to what the problem is. Obtain a history of the present illness from responsive patients, family, or bystanders if your patient's already altered. Responsive diabetic patients will often know what is wrong, especially if they already know they have diabetes. They'll know exactly what's wrong. If a patient has eaten but not taken insulin, then they're going to wind up with hyperglycemia. If they have taken insulin but they haven't eaten, then it's the other way around. So it'll be hypoglycemia. Observe your physical signs and symptoms to determine whether the patient is either high or low. As you see, like Crystal put in there, there's differences. The hypoglycemia is going to kind of mimic shock. The hyperglycemia is going to kind of mimic drunk. Obtain the sample history from a responsive patient or a family member or bystander. So what is sample? What's S? What is S? Signs and symptoms. Good. All right. What's A?
I'll just do all of them. Signs and symptoms, allergies, medications, prior medical history, last oral intake, and events.
Excellent. Yeah, come on, not so shy people. That was good, and good job, Winston, for putting in there as well. Y'all get these mnemonics down to where you can rattle them off in your sleep. All right, you don't want to be still learning these when you get to boot camp. We need you to know them so that you can go ahead and get into the actual hands-on stuff. So, some questions you can ask: do you take insulin? Right when you get to the medication, ask them if they take insulin or any pills to lower their blood sugar. Do they wear a pump? Is the pump working? Have you taken your usual insulin dose? Did you miss a meal? Um, have you had any illnesses like the flu or COVID or any of that sort that might have messed up your ability to maintain your eating with the insulin that you're taking? Or if you just flat out missed a meal, unless if it's type 2 diabetes, they're not going to take insulin, so that part doesn't apply. But you want to make sure they're still eating properly. Look for an emergency medical identification device like a wallet, card. Look on their phone. We talked about a while back. All right. For your physical exam, if they're alert, you really don't have to do it head to toe so much as just talk to them and get that history and stuff. But if they're unresponsive, you want to make sure that there's no underlying injuries or anything that we don't know about because they're not awake to tell us, "Ow, my leg hurts" or something of that sort. So unresponsive patients get the head to toe. Responsive patients, you can focus it. Look for clues about the patient's condition. Be alert for secondary injuries or illnesses, especially if they, like I said, elderly patients that fall from a standing height due to blacking out for a second, which can happen in hypoglycemia. If they hit something on the way down, or even just hit the floor, even if there was nothing in the way, but just hitting the floor could have caused them to fracture a hip or hit their head, that kind of thing. Yeah, Winston, your mic doesn't work, huh? So I'll remember that. All right. Vital signs. You're going to get all your normal vitals, and glucose should be a normal vital. But it's critical that you get it here. If you respond to a possible diabetic patient and you don't get a glucose, I should personally fly out to your area and slap you. But I mean, that's because how do you know what's going on if you don't have a glucometer or get a glucose stick? Now, if you don't have one, I get it. And if it's not in your scope, I get it. But I mean, 90% of EMTs are able to get a glucose stick. Do it. That should be one of the first vital signs you get. Actually, when somebody has an altered level of consciousness, let glucose be the first thing you get outside of the primary. We already talked about the differences between hypo and hyper, so we won't beat that horse. We beat that. Your portable glucometer. Study the operator's manual for proper use in the field. You can talk with your paramedics. They can explain things to you as well as to how your glucometers will work. Do not use the blood from their IV catheter from the flash chamber to get a glucose number. Do not do it. It is going to give you a false reading. I know everybody and their brother does it. Leslie, you don't have to fess up to it. I know that you guys most likely do it on the truck as well. It's really easy and it's great because you don't have to stick your patient twice. However, those glucometers are designed um, to measure capillary bed what your glucose levels are in the capillary beds. If you use venous blood, your numbers are going to be skewed up. They're going to be a lot higher. And so you're going to think that somebody is fine when they really might be hypoglycemic. Or you might freak out with hyperglycemia when they really are fine. Um, I didn't mean to call you out, but I mean, I see it all the time. I mean, even people I work with, they'll do it. And I'm like, stop doing that. It's not, what good, then you may as well not even have the number because it's not accurate. Um, so yeah, everybody does it because it's easier on the patient. But let's be honest, the stick on the finger is not that bad. All right. If they got an IV, the stick on the finger is nothing. So just stick the finger. Know the upper and lower ranges so that your glucometer will function, but also know your ranges for the patient. Okay, good. I'm glad that's the case. I know a lot of paramedics and even a lot of EMTs, they rely on the blood in the flash chamber of an IV. It's just not That's not good blood to use. Um, Normal ranges for an adult, 80 to 120. I always said 90 to 110 when I was in school, but 80 to 120 works better. It's also a wider range. Um, and then as it says, neonates should be above 70. You're going to notice that like babies sometimes will be on the low end. That's okay. Your reassessment, we'll skip through these 4 slides because they're always the same. You're just going to reassess every 5 minutes if they're stable, or I'm sorry, unstable, every 15 minutes if they are stable. I think I said that right. 15 stable, 5 minutes unstable. Reassess your primary and interventions you've done. Make sure that they're still working. And then again, if unable to test for blood glucose values, perform a thorough assessment. And if you have to, err on the side of hypoglycemia because hyper is a much slower onset. Just make sure you tell the hospital, hey, I gave him oral glucose or whatever because I wasn't sure. All right, emergency medical care for diabetic emergencies. Give oral glucose. That's it that what we can do for EMTs. The big thing to remember though is that they have to be awake because they have to be able to control their gag reflex and control their swallowing and not aspirate everything. There's 3 types out there. You have the rapidly dissolving gel, the large chewable tablets, and the liquid formulation. Most everybody carries the gel. That's what you see in the picture. He just holds up better. Um, they all taste like crap, but the gel just works better. You just pop the tip off of it, squeeze it into the cheek into their mouth. Um, you can have them let it like sit in their mouth for a little bit, either up against a cheek or under the tongue, something like that, because your mouth is very vascular. So if you tell your patient, hey, just let this chill out in your mouth for a little bit, under your tongue and around your cheek, yes, they're going to swallow it. That's fine. But if they can just let it sit in their mouth for a little bit, it'll get into the bloodstream faster from those vascular areas inside the mouth. And then when they swallow it, then it'll go through their system like normal and they'll come out of it, hopefully. If once they're altered, though, this can't be given. So keep that in mind. If I give you a diabetic that's got an altered level of consciousness, you have to know not to give them oral glucose. And that's pretty much your only contraindication is whether or not they can swallow it. How much would you give them? Give them the whole tube. Don't measure it. Just squeeze a whole tube in there. Good question. Yeah, because if you go back and look at this, those glucose tubes they're not gradiated. They're not gradiated, and really you can't see inside of them, so you really have no idea if you've given half a tube or anything like that. So if they're hypoglycemic, just empty the tube. Empty it, give it a couple minutes, see where their blood sugar is at. If it's still low, empty another tube if you got it. Wear gloves before putting anything in a patient's mouth. That's just for your own safety. Not to mention theirs. You don't know what's on your hands. So don't make them eat, you know, whatever your last patient had on them or something like that. Follow local protocols for glucose administration and reassess the patient frequently. Usually, if they are having a sugar issue, 1 to 2 minutes, you should see a difference, either in their mentality or in their vital signs or whatever. It doesn't take long. You don't have to wait 5 minutes to check somebody's glucose and see how they're doing. Reassess frequently, provide transport. For the presentation of hypoglycemia, this is what you see most in the field, and this is the real emergency. Hyperglycemia, you know, say it again, slow onset. Yeah, you're going to want to take them to the doctor, unless it's something that they can fix. If it's that they're, you know, they just forgot to take their insulin, but they've got it and they're alert enough to do it, then okay, whatever. But hypoglycemia, because that comes on with the altered mental status so severely, there's not a lot that they're not going to say they can't go to the hospital while they're in this. So our job is to get them back to their normal state of mind. And then if they are known diabetics and they're like, oh, sorry, I didn't mean to do that, let me eat something, then okay, cool. Most of your diabetic emergencies can be fixed in the field. Very seldom do we ever have to actually take somebody to the doctor or to the hospital for diabetes, unless that's their first attack. This new onset diabetes, they didn't know they had it. They had no idea what to do, that kind of thing. But sometimes hypoglycemia can present with seizures. So just be aware of that. And then you're going to go through your seizure protocol, just like we talked about the other night. Some other possible causes: infection, poisoning, hypoglycemia, obviously. Hypoglycemia leads to hypoglycemia. Imagine that. Trauma, decreased levels of oxygen, idiopathic, meaning that we don't know. It can just be something else going on. And fever or undiagnosed epilepsy in children. Sometimes if it's a brief seizure, that may not hurt them, right? But if they start to go down the status epilepticus route, that's a bigger issue. So just treat it like you treat another seizure. Ensure the airway is clear. Move things out of the way so they don't hit them. Place the patient on their side once the seizing is stopped, so that if they do start to vomit or anything like that, it can come out of their mouth. Just make sure when you go to roll them, really only roll them like that if you know that they don't have any other kind of trauma to their spine or to their cervical spine specifically. Don't put anything in the patient's mouth that you want to get back. Bite stick or oral airway fingers is a great way to lose them. Have suctioning ready. And if the patient is cyanotic or appears to be breathing weird, give them oxygen or artificial ventilations if you can. And then, of course, transport promptly. For your altered mental status in general, just know that it may not be diabetes, right? So it could be poisoning, like carbon monoxide poisoning, it could be something they ate. Head injury, post-ictal state from a seizure. We just talked about seizures. Let's say we show up and that's what they're seizing, but it's not from diabetes. The altered mental status, now you're going down that route. Decreased perfusion to the brain. This could be caused by complications of diabetes. It may not be. So hypoglycemia and ketoacidosis, you're going to see that if diabetes is a factor in this, but if not, then usually those aren't accompanied. You can use the mnemonic AEIOU tips. I've never used that, but always suspect and check for low blood glucose in a patient with altered mental status. I love that it even says use the mnemonic AEIOU tips, and it doesn't tell you what those are. So I will Google that because, like I said, I never use it. So you don't.
I know it.
You know it?
Yeah.
Oh, go for it. Take over for a second.
Alcohol and drugs. E is endocrine. I is insulin/infection. O is overdose. U is uremia. T is trauma. I is infection. P is psychiatric. I'm sorry, I'm a little hoarse right now. And S is shock.
So the AEIOU is mostly issues that could be like you said, alcohol, infection, that kind of thing. And then T, you start going into more traumatic things.
Yeah.
Yeah, it's, they didn't even mention that when I was a student. AEIOU tips wasn't a thing. Um, so it's kind of new to me as an instructor, but I mean, it kind of sucks that the slide didn't even throw me a bone for what that meant. But thank you, because I learned from that one too.
Anytime.
Managing patients, ensure the airway is clear. Be prepared to provide artificial ventilation, suction if you need to, and provide prompt transport. So if it's a misdiagnosis of a neurologic dysfunction, which sometimes is the case, right? Where this whole chapter is not just diabetes, it's about endocrine issues in general. Well, it may not be the endocrine glands that's the problem. It may be the neurologic dysfunction, but it just got missed. Sometimes that's the case. Now, occasionally patients with diabetic emergencies are thought to be intoxicated. Again, that used to be really big with the police and everything years back. It's not so much anymore, but it was once upon a time, it was a major problem. A diabetic patient confined by police is at risk. Usually not so much, but still in the slides. An emergency medical identification bracelet, or like I said, their phone, their smartphone. Most people use smartphones now. These can kind of give you clues as to what's going on. Check their blood sugar. A lot of times the cops will call you out to do that before they arrest somebody if they think they'll call you out just to make sure. And sometimes it's both, right? They could be alcoholic and diabetic, or they could be drunk and diabetic. It's not always just one without the other. All right, for airway management, when they start to go out on you, they may lose their gag reflex, and so if they vomit, they're not going to try to clear it out of the airway. The tongue can obstruct the airway, so you're really going to have to pay close attention to this when you have your altered or unconscious patients. Place your patient in the lateral recumbent position if you can, if there's no trauma to the neck, and make sure your suction is available just in case you need it. And that is it for diabetes. Before we move into hematologic emergencies, does anybody have a question? Could alcohol affect their glucose level? Not necessarily, no. Not to the point where we would call it a diabetic emergency. Yes, they could be drunk and having a diabetic emergency, but usually it's not a direct, alcohol is not going to throw somebody into hypoglycemia. Usually it will be because they didn't eat or they dehydrated, and then that kind of stuff will come more toward the end, maybe around the hangover stage, but like not while they're sitting at the bar. If they're having a diabetic emergency at the bar, it's usually independent of the alcohol. Okay. Moving on to hematologic emergencies. So now we're talking about bloodborne issues. All right. So there's 3 disorders that can create a pre-hospital emergency that we're going to talk about tonight. There's a lot more out there, but these are the ones that we're going to talk about. Sickle cell disease or sickle cell anemia, hemophilia A, and thrombophilia. I like that because the last curriculum that we taught all of them, and it was just my eyes glazed over, and I was the instructor. So thankfully, we're only talking about the pertinent ones now. All right, so a real quick anatomy review. Blood is made up of 4 components. You have your erythrocytes, which is your red blood cells, your leukocytes, which is your white blood cells, your platelets, and your plasma. Each of the components of blood serve a purpose in maintaining the body's hemostatic balance. So real quick, what do the red blood cells do? Oh, they're all on the slide. Never mind. All right. Your red blood cells carry your oxygen to the tissues. They also carry your carbon dioxide away from the tissues. They use hemoglobin to do that. That's what binds. So the hemoglobin chills out in the red blood cells, and that's important when we start talking about sickle cell. Red blood cells make up 42 to 47% of your blood volume. All right, your white blood cells, which are called leukocytes, if you want to get technical with it, These make up 0.1 to 0.2 of a person's blood volume. These fight your infections. And when you go to the hospital, if they want to know if you have an infection, one of the easiest ways to do that is to, when they look at your labs, they look and see how many white blood cells you have in your bloodstream. Because when you're fighting an infection, that number goes way up. So if your white blood cell count's high, that tells the hospital that you have some sort of an infection and they need to possibly look at some antibiotics to give you a hand. Your white blood cells also collect dead cells and provide for their correct disposal, and they respond to infection. Platelets make up 4 to 7% of your blood volume. These are responsible for clot formation. They do respond to skin or blood vessel damage, and they assist in forming the clots to stop bleeding. It's pretty much, that's all they do. Platelets don't have a nucleus. When we talk about blood cells, you think cells have a nucleus and they think and they do their own little things and whatever. Platelets don't. Platelets just exist. It's just dried up, hook-shaped things that are designed to catch whenever they're flowing out of a wound. They're designed to catch onto the edge of the wound and catch onto each other, and then that's how they build their scar tissue and scabs. And then your plasma, mostly water. Like I think 90-something% of plasma is made up of water. That's just what gives your blood a liquid medium. Otherwise, you just have a bunch of dry cells hanging out. All right, so the first thing we're going to talk about is sickle cell disease. This is also called hemoglobin S disease. The reason being is because, again, your hemoglobin is what's responsible for carrying your oxygen and your carbon dioxide either to or from the cells. The hemoglobin hangs out inside the red blood cell, which the red blood cell is this nice poofy, looks like a pillow. It's all fluffy and filled up with fluid and the hemoglobin and everything, unless you have sickle cell. Sickle cell disease causes your red blood cells to shrivel up, right? So now they look more like raisins than they do plush pillows or whatever. So there's no room for the hemoglobin inside of them. So they can't carry oxygen, but they still register as being, your body still sees them as red blood cells. So they don't necessarily get filtered out. And you don't get new red blood cells put in. So people with sickle cell are going to be they're always going to have a low O2 sat, and they're always going to feel the effects of it. They're going to be tired more often. They're not going to be able to do a whole lot of strenuous activity and that kind of thing because their O2 sats are always so low. This is predominantly in the people of African, Caribbean, or South American ancestry. It is in Mediterranean, Middle Eastern people, but it's not as common. And all newborns in the United States are tested for sickle cell disease shortly after birth. We already talked about this third bullet here with the misshapen RBCs, red blood cells. Leads to dysfunction in oxygen binding and unintentional clot formation. That's the other aspect of this. When they start to look like that sickle, they're hooked like that, they start to take on more characteristics of platelets than they do red blood cells. They're not able to carry oxygen, but they are really good at hooking onto things and getting stuck. So you wind up getting unintentional clots, which leads to your increased risk of strokes, embolism, thrombus floating around, all that kind of stuff, DVTs. This can result in hypoxia, pain, and organ damage. Sickle cells do have a short lifespan. It doesn't really take long for them to die off, which is good. This results in more cellular waste products in the bloodstream, which can contribute to sludging or clumping of the blood. Again, eventually the white blood cells will take care of these, but the amount, because you only have so many white blood cells in your blood at any given time, unless you have an infection. They're not very fast at cleaning out these sickle cells, so it does tend to build up. Some complications for sickle cell is anemia, which means not enough oxygen in the blood. Gallstones, jaundice, splenic dysfunction, vascular occlusion with ischemia. They are at higher risk for heart disease, ischemic heart attacks, strokes, that kind of thing. Joint necrosis, pain crisis, it doesn't, it can hurt. They can definitely register a lot of pain from this. And the problem with this is it's systemic, head to toe, because it's everywhere that the blood can reach. Acute and chronic organ dysfunction, retinal hemorrhages, increased risk of infection. Your white blood cells are already busy trying to get rid of all the dead red blood cells. You run the risk of infections taking hold because your white blood cell count's not as able to respond quickly. Many of these complications are very painful and potentially life-threatening. The patient is also more susceptible to infections, like I was saying. That slide's just more of the stuff that we were talking about. So here's this picture is pretty good. Shows you what sickle cell looks like. It's not all the red blood cells, obviously, or you would suffocate. The nice pillowy ones with the divot, those are what your red blood cells are supposed to look like. When they shrivel up, they get this curved, hooked look to them. They're sharp and jagged. That's your sickle cells. Clotting disorders, hemophilia. This is rare, especially for the amount of people that we have in the United States total. Only 20,000 typically have hemophilia. Unfortunately, if you're a guy, you get the short end of the stick on this one. We're much more likely to get it than a female is. People with hemophilia A have a decreased ability to create a clot after an injury, which can be life-threatening. So, you cut yourself shaving, a little nick that you can't even see can look like a murder scene. Imagine what an actual injury would do to you if you had hemophilia. You wouldn't clot. So if you're the EMT and you're trying to do bleeding control on somebody with hemophilia, direct pressure and stuff like that, it's probably not going to work. You're going to wind up needing to do a tourniquet for something that should never have needed a tourniquet in the first place, just because it won't clot. You'll bleed. You can put every 4x4 you've got on the injury, it'll bleed right through it and keep on going because there's no clotting factor. Patients with hemophilia A typically have IV factor VIII replacement infusions, which helps the blood clot. Usually this is done at the hospital or at a clinic that specializes in it. This is either close at hand or with them if they can bring it home with them. It's something that they can possibly do at the house, but if they don't have it, they have to go back to the doctor to get it done. Common complications include long-term joint problems that may require a joint replacement. Bleeding in the brain, especially if they got hit in the head, and it really doesn't take much, right? When you can't clot, a small bleed will just continue to bleed, and then they're going to have problems. Thrombosis due to treatment. If those clotting medications that they take, if they think of it like insulin, if they take too much of it, it's going to lead them too far off into the other end of the spectrum. All right, another one, thrombophilia. This is a disorder in the body's ability to maintain the smooth flow of blood through the venous and arterial system. Concentration of particular elements in the blood create clogging or blocking issues. This is kind of the other end of this spectrum. You're not free bleeding. Now you're dealing with thrombuses everywhere. Thrombophilia is a general term for many different conditions that result in the blood clotting more easily than normal. Sometimes this is inherited. Medications can do this. Patients with cancer sometimes will have this problem. Clots can spontaneously develop in the blood, and depending on where they develop, you're going to have the associated problems. If it's in the arteries, it's going to get stuck down it could get stuck down in the legs. You could have a stroke if it goes toward the head. If it's stuck in the veins, or if it's forming in the veins, then you're going to run into the problem of having pulmonary embolisms or pulmonary thrombosis, that kind of problem. All right, deep vein thrombosis. I actually know people with this, and it kind of sucks when it flares up. There's some things that they can't do that you would think, or that are just normal. Like a lot of people don't realize that this is a problem for some. This is a common medical problem in sedentary patients and in patients who have had recent injury or surgery. You may encounter several methods to prevent blood clot formation, including blood thinning medications, not to be confused with aspirin. Aspirin's not a blood thinner. compression stockings, mechanical devices, so on and so on. Some risk factors: recent history of a joint replacement and complaints of leg swelling could be DVTs. Travelers, trucks, long distance bus drivers, people like me who drive cross country all the time, we're at risk for this. Bedridden nursing home patients, if they're not getting turned like they should be every so often, can have this problem. A buddy of mine's got it, and because of that, he can't make like long flights. He has to be able to get up and stand up, let his blood circulate and all that. It takes him a long time to drive. If he's going to do a cross country drive, it's going to take him a long time because he's got to keep stopping and getting out. Some treatment for DVTs: anticoagulation therapy. Aspirin sometimes will be given for this. In hospital IV medications, transition to oral medications before discharge. Self-administered subcutaneous, injectable, or oral medications. Again, like I said, you may see warfarin or aspirin as a daily regimen, that kind of thing. Patients prescribed medications to treat DVT are at increased risk of bleeding complications, especially if they overdo it. And minor trauma is more likely to produce severe internal or external hemorrhage because they're taking medications to stop they're purposely trying to stop their clotting. And if you think about it, aspirin, for example, has the risk of giving you a ulcer. NSAIDs have a risk of giving you an ulcer. Gastrointestinal bleeding is common. And then, so now the medication you're using to stop yourself from clotting, if that medicine directly creates an ulcer where you start bleeding, now you're going to continuously bleed into your stomach. And you're going to wind up with those GI bleeds that we talked about earlier. I think it was last Thursday when we talked about GI bleeds in the gastrointestinal tract. So a clot from the DVT can travel from the patient's lower extremity all the way to the lung, causing a pulmonary embolus. And pulmonary emboli can cause chest pain, difficulty breathing, or even sudden cardiac arrest. So these things are no joke. $742. All right. So we'll go ahead and move into your scene size up, or your patient assessment for these. This is going to be pretty similar to any other emergency you come across, right? So your scene size up will always be the same. BSI, scene safety. Most sickle cell patients will have had this crisis before. A lot of them are born with it. Wear gloves and eye protection at a minimum, especially when you're dealing with blood disorders, because if let's say they accidentally nick an artery, they're going to be shooting blood for a while. So we don't want that to get all over us. Determine the number of patients involved. Being that it's a medical issue, usually it's only going to be the one patient if you're responding to a hematologic emergency. Be alert for possible trauma and consider ALS. For your primary, ABCs, right? It says here, is the patient in pain and of African American or Mediterranean descent, that is not your concern in the primary. Your primary is your ABCs and life threats. However, that being said, you're looking at your patient, right? So you're not going to jump to something way down in your assessment, but you can go ahead and note that when you're starting to try to figure out what your nature of illness is. This is a good way to know that, because the demographics are not in their favor for possibly having these hematologic disorders. So if they are of this descent, now you've got red flags for possible sickle cell. Form C spine immobilization if you need to, if it's trauma, which we'll get more into that when we get to the trauma module. Form a general impression, are they sick or not sick? Assess the patient's airway and breathing. Same thing, if they're below, I don't want you to get so caught up around the whole 94% at this point because you're still in your primary. So think of it from their actual breathing. Does it look good? Is it 12 to 20 a minute? Is it adequate depth, equal rise and fall of the chest, that kind of thing? If it is, then fantastic. And if you want, you can throw them on a nasal cannula. If it's not, or if they have an altered level of consciousness, then yes, we're going to go ahead and put them on the non-rebreather. And then if we can always dial it back later on. If they're not breathing properly, say they're breathing only 6 times a minute, then you're going to manage that. That's respiratory distress. You're going to bag them. That's what that slide means. All right, for your circulation, um, sickle cell patients have an increased heart rate because their body is getting oxygen starved because they don't have enough red blood cells that can carry it. So remember that. Be alert for signs of acute blood loss, pallor, weak pulse, hypotension, any of those signs. Note bleeding of an unknown origin. So if they're having a nosebleed or if they're coughing up blood in their urine or stool, that's blood coming from something internal that we can't fix. We can't put a bandage on that, but we need to note it. And again, it falls back on their primary. So if it's coming out of their mouth, we need to make sure that they don't start choking on it. Be alert for signs of hypoxia, which is due to blood loss, and make your transport decision. If this is what you're dealing with, you're usually going to try to get to the nearest hospital, um, or I'm sorry, the nearest trauma center. Or you can take them to, like, for example, the Band-Aid station in Poplarville. Um, you can go there if you need to, if they're unstable. But if their vital signs are stable and it doesn't look like they're going to crash on you, then you can go ahead and move on to a, yeah, I hated saying that. I got recorded saying it too. Um, you can go ahead and go to Wesley or well, not Wesley. You can take them where they want to go. You can take them to Forest General. It's up to you. Investigate your chief complaint. All right. Be alert for physical signs indicating sickle cell. So swelling of the fingers and toes, priapism, jaundice. These are all signs. If you have priapism and no sign of trauma, that's a big red flag for sickle cell. It's also telling you that whatever it is bad enough that they're having a head problem, despite not actually getting hit in the head. Is a Band-Aid station in Port Sulphur. You should also ask the following questions. Is the pain isolated to a single location, or do you feel it everywhere? If it's a sickle cell anemia issue, they're going to feel it everywhere. It's like their entire body is fighting against them. Do you have any visual disturbances? Are you experiencing nausea, vomiting, or abdominal cramping? Or are you experiencing, remember the pertinent negatives, are you vomiting? Like if your patient's vomiting, but there's no nausea, you can ask them, like, do you feel this coming on, or are you just puking? Is the patient experiencing chest pain or shortness of breath? Get your sample history, which we already talked about what sample stands for. Um, Basic questions, have you had the crisis before? How long ago? Um, how did it resolve? Did you fix it? Did somebody else have to do something? Do you have to go to the hospital? Do you want to go to the hospital? That kind of thing. Did you have a recent illness? That's big, especially when you start thinking about what we talked about with DVTs. Recent illness, recent surgeries, that kind of thing can lead you down that road. For your physical exam, focus on major areas, joints, that kind of thing, because what's going to happen is you can get some cells that get kind of stuck there in those gaps. So your patient may start to have arthritic pain. They won't really swell so much unless it's really bad, but they're going to feel that they're going to have the pain of like an arthritis. Evaluate and document mental status using the AVPU scale. So are they alert, verbal, painful, stimulus only, or unresponsive? Get your vital signs. Make sure you get them all, including, and this is one of the most missed vital signs, is neuro, your pupil reactions. Make sure you get those when you're dealing with these, because if they're having hematologic issues that's causing their O2 sats to drop, you're going to see that in their mental status, in their neuros. For reassessment every 15 or 5 minutes, depending on how your patient's doing. Make sure that your interventions are still in check. Make sure nothing that you've done is not working, or is no longer working. If you're in a hospital, your nurses are going to set up IV therapy for hypotension. They're going to be trying to maintain blood pressure, and then they may have to do a transfusion. Communicate with hospital staff for continuity of care and document clearly. All right. The only other thing else that I want to say, and this is how we're going to end the chapter for the night, is if you're actually trying to take care of somebody with a hematologic disorder, there's really no life-saving intervention that we do. We pretty much just try to make them feel better while we get them to the hospital. So be have a good bedside manner with your patients. Understand that things like sickle cell are extremely painful, and you literally hurt everywhere. Everywhere that blood can get, which is every inch of your body, is going to be hurt, especially in the joints. So imagine having arthritis in every single joint with a migraine, feeling like your bones are broken. Um, that's kind of what your patient is dealing with. So if they're making a scene, just let them do it. There probably isn't. They're not really overblowing it as much as you might think they are. Oxygen, we underestimate the effects of oxygen when you give that to them. It can make them feel better, even if it's a placebo effect. It can really help. Place your patient in a position of comfort and transport them to the hospital is pretty much all you can do. And like I said, be be empathetic. See what you can do. Sometimes your paramedic may be able to give some analgesics or something, but even then, it just depends on what's going on. So don't promise them anything you can't get them, but do your best to make them feel good. And that's going to be it. Let me get your pin for the night. While I'm doing that, do you guys have any questions? Nothing. All right. Unless I put everybody to sleep. Your pin for the night is going to be B as in Bravo, C as in Charlie, 19, so 19, and then D is in diabetes, BC19D. There you go. It's on there. Um, don't really have anything new for you guys other than just keep up with your tests. This is a large module, so we still have a good ways to go before we reach the next module test. But that being said, don't fall so far behind on your quizzes, because you don't want to be 1 or 2 nights away from the module and then realize you have to take like 15 tests before you even get to the module. So try to keep up with those. And otherwise, y'all have a good night, and we'll talk on Thursday.